Welcome back to the Head and Neck Oncology Journal Club. I'm your host, Krishna Kumar Thankappan, and this is episode 13. This week we are covering a landmark trial just published in the Lancet Healthy Longevity by Ortholan and colleagues on behalf of ELAN Group and Gortec. The ELAN-RT trial is the first randomized controlled trial comparing hypofractionated split-course radiotherapy versus standard fractionation in frail, older patients with head and neck squamous cell carcinoma. Here is the context. In the EU, 38% of patients diagnosed with head and neck squamous cell carcinoma are aged 70 or older. Standard curative radiotherapy is 60 gray in 35 fractions over 7 weeks. But for frail older patients, this is a significant burden. 5 weeks of daily treatment, substantial mucositis, and frequent travel to the radiation facility. In practice, many radiation oncologists have adopted hypofractionated split-course radiotherapy for these patients. Higher doses per fraction, fewer sessions with a break in the middle. The rationale is reduced toxicity and travel burden. The risk is that tumor cells may repopulate during the break. Despite being widely used for decades, this approach never had been tested in a randomized trial. The ELAN-RT trial was a non-inferiority open-label RCT conducted at 30 centers across France and Monaco. They enrolled patients aged 70 and older, classified as frail by the ELAN geriatric evaluation with stage 2 through stage 4 head and neck squamous cell carcinoma, unsuitable for surgery. Patients were randomized 1:1 to standard fractionated RT, that is 70 gray in 35 fractions over 7 weeks, or hypofractionated split course radiotherapy, 55 gray in 20 fractions, delivered as 2 courses of 10 fractions over 2 weeks each, separated by a 2-week break. The primary endpoint was the proportion of patients alive with complete locoregional response at 6 months. The non-inferiority margin was set at 16%. 202 patients were randomized. The median age was 82 and 64% were aged 80 or older. 73% had stage 3 or 4 disease. This was a genuinely frail population with an average 2.3 geriatric frailties. Median follow-up was nearly 5 years. Coming to the results, the primary endpoint was met. In the intention to treat analysis, 35% of patients in the HNSCC group were alive with complete locoregional response at 6 months versus 33% in the standard RT group. The difference was plus 2% with a 95% confidence interval of -11 to +15. Non-inferiority was established. But here is an important caveat. The expected response rate in the standard arm was 70%. The actual rate was 33%. This population did far worse than anticipated, highlighting how limited our outcome data are for frail older patients. Coming to results, and that is where the story gets more complicated. Median overall survival was 13 months in the HNSCC group versus 18.9 months with the standard fractionation, a nearly 6-month difference. The hazard ratio was 1.32 with a confidence interval of 0.97 to 1.81, not statistically significant, but clinically concerning. Progression-free survival showed a similar pattern, 7.8 versus 12.1 months. The authors point out that some of the early excess deaths in the HNSCC group occurred within the first 2 months and were not directly treatment related. This may be partly attributable to chance in a small trial, but the trend is consistent across multiple survival endpoints. On the toxicity side, HNSCC showed a clear advantage for one outcome, that is radiodermatitis, grade 2 or higher was significantly lower at 12% versus 31%, and the p-value was significant. Overall, grade 3 to 5 adverse events trended lower with HSCRT at 36% versus 47%, though this was not reaching statistical significance. Feeding tube was also trended lower. Late toxicity and quality of life scores were similar between the groups. And here's the bottom line. The ELAN-RT trial met its primary non-inferiority endpoint. Hypofractionated split course RT did not compromise locoregional control at 6 months compared with standard fractionation. It also appears to be better tolerated, particularly for skin toxicity. But the survival data favor standard radiotherapy, and that signal cannot be ignored. Standard fractionation should remain the default for frail older patients who can tolerate it. HSCRT is a reasonable alternative only for patients deemed unsuitable for standard RT after formal geriatric assessment, particularly those with significant comorbidities, limited life expectancy from non-cancer causes, or logistical barriers to daily treatment. And critically, the prognostic subgroup data remind us not to lump all the frail older patients together. Some of them have meaningfully long survival and should not be undertreated. That is episode 13. See you next week. This is from Head and Neck Oncology Journal Club. Thank you.